so that this will allow us to take the message that we're going to hear and listen to it. And I want us to not just listen to it live tonight, but listen again, because Alana has agreed to join us for a part 2. So this is just the start of understanding and listening to health disparities. So welcome, everyone. I want to introduce a friend. Mary, I'll just tell you, Alana wears that pink and green with me. So we're sorority sisters. So Mary is a Delta on the line. So that D9 connection is love through and through. There you go. See, she's got, so we have that relationship and that understanding. So I want to welcome Alana to the call. She is, as her bio said, and everybody please take the time to read it so you know what a gifted, passionate, and very experienced speaker we have. She is, as it says, a very sought after strategist, and we are so grateful that she has agreed to share with us her insights and understanding around health disparities. I loved what it said about her in the beginning, that she's an equity engineer, which means she knows how to connect healthcare and clinical trials and people. She's also the bold voice of what you see behind you, the Bold Bet podcast. So we're going to ask you to say something about that to this group so that we can chime in and learn. She brings 25 years of experience to us. She understands cardiology. She understands oncology, neurology, rare diseases, and women's health, something that is important, chronic disease as well as specialties. She's built her reputation on breaking barriers and championing diversity in clinical research and driving innovation across all phases of clinical development. So along with that bold Bet podcast, I want to recognize that more recently, she has launched her own consulting group, CEO of Relane Consulting. This is a very important organization because it's a networking and connecting organization. What she does is she equips other organizations and leaders to advance what we're talking about, health equity. And she embeds they embed inclusive practices and reimagine what leadership should look like at every level. So we want to give her a big hello and welcome and support her. She's taking time away from many other things, working on her master's in public health policy. And so here she is to talk with us today about health disparities. Take it away, Alana.
Thank you so much for that introduction, Lisa.
Sure.
I am going to share my screen because I did make a few slides.
Okay. You should be able to. Are you able to share? Let me know if not.
Oh, it says,
Oh, no, I can do that.
hold on.
I'm going to share screen options. Multiple participants can share. You should be able to now.
There we go.
Did that do it? Okay.
That did it.
All right.
You should be seeing my screen soon.
Okay.
Let me know if you cannot see my screen.
Understanding health disparities, building awareness, shifting outcomes, and betting on equity. We got you.
All right, perfect. All right. As Lisa gave a quick introduction, I am Alana Miller. I want to welcome everyone. Thank you so much for being here. And in bold bet style, I like to say, playing it safe, never change the game. Today, we are betting on awareness and equity. I'm truly honored to be here to talk to you today about health equity. It is a space that I have devoted my career and my heart to. Again, I bring 25 years of global clinical trial experience. I help to support strategy. I'm also the founder and CEO of Relane Consulting and the host of the Bold Bet podcast. I help leaders and organizations embed equity, inclusion, and innovation into the way they operate. My academic background is in biology. I have a biology degree from Hampton University, and I'm currently pursuing my master's of public health from George Washington University. And the whole reason that I'm doing that is because I am truly dedicated to health equity. I want to deepen my ability to help bridge science, policy, and community impact. Beyond my professional journey, my passion really is rooted in lived experience. I was born and raised in St. Louis, Missouri, and it is one of the most segregated cities in the US, and where inequities really shape the resources, opportunities, and health outcomes that are available to communities like mine and yours. As I progressed and left St. Louis and went to Hampton, I chose to continue my career, build my career in Dallas, Texas. And I started first working as a researcher at Parkland Hospital. And if you know anything about Parkland, it's actually the hospital they took President Kennedy to after he was, after the assassination of President Kennedy. He went there. It's a teaching hospital in Dallas, but it is also a federally qualified healthcare facility. So it's the county hospital, if you will, in Dallas. And I truly, that's where I began to see how impactful, how we were impacting our health outcomes by where we live, by our social determinants of health. And I'll talk to you a little bit about those later. And so those lessons that I learned there really helped me to understand about representation and connection, and that those things really aren't just nice to have in research and in health, but they're critical for health outcomes, for impact of people in their everyday lives. So this work is personal for me. Before my father passed away, he participated in a clinical trial, and I had the opportunity to see a lens there too. So as a child of a person who was participating in clinical trials and being impacted by health outcomes that were challenging, he ultimately passed away. But I did have the opportunity to be with my father that day. I had the opportunity to see him through his entire disease process, and that was eye-opening for me as well. So I just say that I come to this conversation not only as a strategist and a leader, but as an equity engineer. I work to dismantle barriers, amplify diverse voices, and build solutions that really create lasting impact. And so my mission is to ensure equity is not just a side conversation in healthcare, but the standard, and it's what we all expect and demand. So I want to start here. Why does this even matter? The National Institute on Minority Health and Health Disparities defines health disparities as preventable differences in burden of disease, injury, violence, or opportunities to achieve optimal health experience by socially disadvantaged populations. And health equity, that's just when everyone has a fair and just opportunity to be as healthy as possible. I like to bring this forward because I always think this is really interesting, or it was at least interesting to me when I first learned out that the major recognition of health disparities began nearly 40 years ago. And it was with the report of the Secretary Task Force on Black and Minority Health. It was called the Heckler Report in 1985. And it documented persistent health disparities that accounted for about 60,000 excess deaths per year. And it really synthesized the way that we advanced health equity. The Heckler Report then led to the creation of the U.S. Department of Health and Human Services Offices of Minority Health, and influenced federal recognition of the investment of many aspects of health equity. In 2003, the Unequal Treatment Confronting Racial and Ethnic Disparities in Healthcare report identified systemic racism as a major cause of health disparity in the United States. I always thought that was really interesting because 40 years later, we still battle this issue, and we've known for 40 years that it was an issue, and we continue to battle this. This here speaks to social determinants of health, and this Kaiser Family Foundation framework that you see on the screen really shows us the drivers of health disparity. So, economic stability, neighborhood, education, food, access, social context, and the healthcare system all matter. And racism, as you can see, really cuts across all of them. And it shapes where you live. It shapes the quality of the schools that you have access to. It shapes the kind of food you can buy and whether or not you can even find a trusted doctor. According to the National Community Reinvestment Coalition, they're called the NCRC, where you live is one of the most important or significant components of overall health outcomes and life expectancy. Up to 60% of your health is determined by your zip code. Isn't that amazing?
You said
60,
60%?
up to 60% of your health is determined solely by your zip code. Isn't that amazing?
Are there things in that zip code? So the school, can you tell us more about that zip code?
Sure, sure.
Okay.
It's truly due to the nature of the communities we reside in, like whether it has wealth, whether or not there's a strong community investment, whether or not there are hospitals and health centers that are present. Your social and built environment really determines your individual and community health above personal behavior and clinical care. So disparities aren't random, they're systemic. I think that's the point here. They're predictable and preventable. So it is truly, I've heard people say that your ZNA is more important than your DNA. And when they say ZNA, they're talking about your zip code. Your
Mm.
ZNA is more important than your DNA. Where you live speaks to your economic stability. Where you live speaks to your physical environment. Where you live speaks to what type of educational opportunities you may have at your disposal. You may be limited by your children may be limited by the education system in your neighborhood. You may not have access to fresh foods in the neighborhood that you live in because of the grocery store availability that is close to your neighborhood. So if you, in some instances, people need to walk to the grocery store. If the closest grocery store doesn't even have fresh food or fresh vegetables and fresh fruit, all they have is canned goods, you're limited simply by the fact that you live in that zip code.
Okay. Thanks.
Yeah. And so I just want to talk here about how social factors influence disease and mortality. And this side is really speaking to how inequities flow downstream. What it's showing us is that our health outcomes, things like how long we live and what we might die from, don't just happen randomly. Again, they're connected to a whole chain of things that start way before you even get sick. So, first is social factors. Things like income, race, gender, sexual orientation. These are really the starting blocks. If you're born into a family with limited income, you don't start the race of life in the same lane that somebody else who's born with financial security is. You don't. Same as being part of a marginalized group, whether it be racial or LGBTQ. You're facing barriers that others may not even recognize or see. Living conditions, those factors that shape the conditions you live in. So if you live in a neighborhood with constant stress or where discrimination is everyday part of life, that takes a toll on your body. If the area you live in doesn't have good schools or safe jobs or affordable healthcare, that's another issue that you deal with. Or let's say you live by a factory that has, consistently pumping out some sort of toxin, causing environmental exposure. That's a real problem too. It's like the environment is either setting you up to thrive or almost breaking you down. Health behaviors. So now here's where people usually point the finger. It's like, oh, people smoke too much, they don't eat healthy. But here's the thing, if you're like I said, if you have a grocery store in your neighborhood that is mostly corner stores and fast food, then poor nutrition really is it even a choice? It's just what's available. It's what you have at your disposal. It's what you can get to quickly. If you're working 2 jobs to pay the bill, to pay the bills, then when do you have an opportunity to go to the gym? You may not even have access to gym equipment. I'm a huge proponent of being able to use body weight to work out, but you know, if you wanted to use some sort of equipment, you may not have access to it. And if your daily stress is sky high, alcohol or smoking might feel like the quickest way to cope with some of those things. So behaviors matter, but they are shaped by the conditions around you. Well, let's talk about disease and injury. So over time, all of this stuff is adding up. We start to see higher rates of diabetes, high blood pressure, cancer, mental health struggles, even injuries from violence based on the community that you may live in. This is usually when people finally show up at the doctor at this point. But by then, the result of these years of upstream factors, so all these factors that you see at the beginning, all this stuff is compounding over time. And now you have a problem that you can't deny. You feel your heart having an issue. You may be having issues that are so impactful to your mental health that you can no longer ignore them. And so now you finally show up to a doctor to see what's going on. And so what's the end result of that? Different death rates, different life expectancies, depending on race, income, education. Some groups live 10 to 15 years less than others just because the cards weren't dealt from the very beginning. And that's why life expectancy can vary based by race, zip code, and income. So the takeaway here really is that differences in health outcomes between groups aren't just about personal choices, they're about structures, systems that shape those choices. And it's not enough to just tell people to eat better, exercise more. We need to make sure that everyone has conditions that actually allow them to live healthier. I apologize, this is so small. Can you if hopefully y'all can see this. But this really speaks to how race, poverty, unemployment, health insurance are all tied together and overall impact people's health. So the poverty chart, which is on the left side, this is from the United States Census Bureau. We've got these poverty rates over time. And here's what really stands out on this slide is that you can see that Hispanic and Black families are consistently at the top of the chart. See those at the top of the chart up there, which means that they've had higher poverty rates year after year. White and Asian families are lower down on the chart. Now, everybody's rates have gone down since 2009, which is good, but those gaps are still very present. And so the progress hasn't been equal. On the right side, you're looking at the uninsured chart. Give me one sec. I took a cough drop before this to try and get rid of this. It's not helping. Cough drop is not helping me. It's fighting me. But you see the uninsured chart. This is presented by race and Hispanic origin as well. And the story really looks similar here. Hispanic communities still have the highest number of people without insurance. Black communities are next. And then you have white and Asian groups that are lower. Being uninsured matters because it often means that people can't afford to go to the doctor. And so something is really wrong and like you can no longer deny it. I'm forced to go to the doctor and I'm usually going to the emergency room. I probably don't have a PCP that I see regularly. Again, just using the emergency system as a healthcare system, which is not what it's meant to do. When you go to the emergency room, that's usually urgent care. It's an urgent situation going on. The physician expects to see you one time. They don't know you. They don't know your history. You walk in the door and they send you somewhere else. They're not going to see you again. Even if you show back up at that facility in the emergency room again, it may not be likely that you even see that same physician again. So you're not getting the managed care that you need when you use the emergency system as a means of health care. It's harder, it's way more expensive, when you go that route, and it's harder to treat overall. Usually, that is what's contributing to poor health outcomes is later diagnoses. And so when you put these two together, you really see the cycle that high poverty means less stable jobs, which often means no insurance, and that can lead to worse health. It's not about people making bad choices. It's about the system making it harder for certain groups to stay healthy. And so here's this. If we really want health equity, we can't just look at hospitals and doctors. We've also got to look at jobs. We've got to look at income. We've got to look at whether or not people can afford health care coverage. Right now, the system is set up in a way that leaves some groups out fairly consistently. We can see that here. So that's why equity focused policies, that's why my MPH is focused on policy, because that's the structural change. We need to change the top of this rung and not just work on the bottom. But those things are things that are targeted at making healthcare more affordable and making sure jobs come with benefits that can help to support health equity. And those are so important. It's not just about fixing health, it's about fixing the conditions that shape health in the first place. I'll pause to see if there's any questions because I told you this is my passion, so I could just go. So you gotta jump in and stop me if you have questions.
Any questions, you all? They usually pipe up at the end with some
Okay.
questions.
We can do
So,
we can do that. We can keep going, but feel free to
mhm.
jump in. This is I hope this is a conversation more than me sort of preaching at you. Um I I encourage you to go and find this um PBS special. It's called Unnatural Causes. Has anybody ever heard of that? If you have, just raise your heard of Unnatural Causes. It's really interesting. That was actually the very first thing in my MPH program that they had us watch. They said, watch this before you come to class on day one. Watch Unnatural Causes. It's a documentary that PBS put on. It's actually older. It's an older documentary, but very, very good. And it shows us that segregation and systemic racism doesn't just divide neighborhoods. It can literally make people sick by elevating those stress hormones, blood pressure, and heart disease. And so just I have on the slide over here, you can see some of these numbers where you actually see that hypertension in the case of cardiac disease or hypertension specifically, African Americans are about 40% more likely to have high blood pressure. Maternal mortality, Black women are 3 to 4 times more likely to die during pregnancy related causes. Life expectancy for Black Americans on average is 4 years fewer than white Americans. And by race, even more. So Black Americans, higher mortality from prostate cancer, breast cancer, kidney disease, stroke, and you can see that in that chart up above. You can see Native Americans 3 times as likely to have diabetes, higher heart disease, and Hispanic Americans 2 times as likely to have diabetes, 3 times as likely to die from HIV and AIDS. Um, I wanted to talk about the African American experience a little bit here and just sort of speak to some of the things that we've heard about in the past. To understand disparities, I'm a firm believer that we can't ignore what is in front of our face. We have to understand history, we have to respect history, and we can't simply dismiss it. There's some truth behind this history. There's something we can learn from it, and I believe we can grow from it. I think we've probably all heard of the Tuskegee syphilis study. Has anybody here heard of that? Raise your hand if you've heard of that Tuskegee study. And what happened during that Tuskegee study was that Black men were deliberately withheld treatment for syphilis. And I don't know if are those chats for me? I think I can see them.
I'm
Okay.
making notes and I'm following the chat if there are
Okay.
questions. So as you point out some things, I just put it in the chat for the group.
Okay. Perfect.
Mhm.
All right, that Tuskegee study, I don't know if people know a lot about it or the specifics. I think many people think that what happened was they just weren't given treatment, and that is true. They weren't given treatment, but what I think is even more hurtful when we hear this story is that at that point, the treatment was known. They had a treatment that would had been discovered and had been proven to work, and these Black men were actually denied that treatment. They weren't given the opportunity to receive a treatment that was well known. Henrietta Lacks. Have we heard of Henrietta Lacks? HeLa cells. If you work in the science field and you hear HeLa cells, I used to hear HeLa cells all the time, right? So I've been working in the science field for over 25 years, and I had no clue that HeLa was Henrietta Lacks. That is where they get the HeLa from. And these cells were taken from her without consent and then commercialized with no payment to her. Her family was never made aware. She was never made aware. And so science benefited from her cells still to this day, still benefits from her cells. And luckily at this point now, the information has been brought forward. I believe the family has been compensated, and at least awareness is there of what happened. But I think we even still have some biases today, right? Black patients are still less likely to receive adequate pain medication. That still happens. Um, I used to work for a different pharmaceutical company back a few years ago, and I was speaking to some of the Black female physicians that I worked with there, and they spoke about their training. They were older, so I don't know that this still happens. I hope not. They were older, and so they mentioned though, like during their training, they were trained that African American women didn't need as much pain medication because their skin was thicker. That was what they were trained on. I mean, it wasn't like, oh yeah, a big secret. This was the training. African American women had thicker skin. African American people in general had thicker skin, so you don't have to worry about giving them pain medication. That was a training. Even Serena Williams almost lost her life during childbirth because doctors didn't believe her. And that science of stress, really that chronic racism increases what's called the allostatic load, and that's how the body wears down faster. We always talk about how Black don't crack. It can crack. It may look good while it's cracking. It can crack. And so we have to pay attention to that because that allostatic load from stress, from racism, from always having to fight from the bottom up can impact you negatively as well and shorten your lifespan. If you've ever known somebody who got dismissed in healthcare, raise your hand or raise your hand in the chat. I'm just curious. Have you ever felt like you've known someone who got dismissed in healthcare? Yeah, it's unfortunate. But I hope that we get to a point in this presentation where we talk about some solutions too, because I don't want to just lay the sob story down and then we don't talk about how can we get better from this. I think we can.
Alana, are you going to speak to demystifying though the clinical the trials, the Tuskegees, this all of that? Are you going to be able to help people understand what is different now and why it won't happen again? Because many people still think it will happen just because you say it won't. Are you able to speak to that?
Absolutely. And I'll speak to it more on the second on session two, but I can absolutely touch on it now. There have been major advances in the expectation to protect patients over the years. The legislation that has come about because of things like Tuskegee, and Tuskegee's just one. There have been many, and it's not all been Black people. It has been, there have been trials that have negatively impacted the Asian patient population, the American Indian population, women, in general. There have been issues across the board that have impacted multiple races and ethnicities, and as those things come up, they end up resulting in legislation. They end up resulting in fail stops so that people can be protected. And so there are a number of protections that have been put in place. I also like to bring up the fact that now we have a more diverse workforce in the clinical research field too. So you have people like me and other African American women and men who are right there watching and paying attention to things head on and catching things when things aren't said right, or when things aren't shaped right, or when inclusion criteria or logistical issues are brought forward in trials that will negatively impact the enrollment of African American community or negatively impact their outcomes, our outcomes. So we're there, in addition to having legislation that supports policies that support protections. It is there. But I will definitely speak more to that on the second topic.
Okay.
So I want to talk a little bit about why social factors influence outcomes, because people are always surprised about how social factors can influence negative outcomes. But discrimination in healthcare isn't just about people's feelings getting hurt. It's about some real consequences. People who experience discrimination in healthcare are likely to postpone treatment. I don't want to go and subject myself to this negative experience where somebody's looking down at me when I check in at my doctor's office, or somebody doesn't address me well when I check in at or just doesn't understand my culture and my background. I don't want to go and experience that. I want to pay for that. They're more likely to underutilize preventative care services. So, like I mentioned, they tend to go to the ER for preventative issues instead of getting a regular physician or a PCP or primary care physician that can help support you with your long-term illnesses. They often have lower medication adherence. Maybe they don't understand how you're supposed to take this medication and nobody properly explained it to them. And so there may be understanding issues. And I heard someone speak today about health literacy and the lack of health literacy, and how there's sometimes a lower health literacy. And I think people often mistake that to mean you're saying someone's not intelligent, but there is literacy relative to every industry out there. I don't have a high literacy as it relates to the NFL. My NFL literacy is low, non-existent almost. My literacy as it relates to IT is low. I'm a low literacy when it comes to IT, and some people fairly so, because it's not an industry that they work in, or it's not something that they understand on a day-to-day basis or hear about on a day-to-day basis, have a low healthcare literacy. And because of that, we need to make ourselves aware in the clinics, make ourselves aware at the pharmacy, that sometimes people don't understand what you're saying. You said something so fast and so quick because it is your everyday job to hand out medications, that you didn't explain what all those acronyms mean on that bottle. What does BID mean on a bottle? Why you give me a bottle, give me my medication that has take it BID? What does that even mean? We should take our time and explain to patients so that they can be as literate as we are when it comes to things like healthcare. Lisa, you came off mute. Did you want to say something?
I thought you were asking the question, so I
Oh,
put BID and it's twice a day.
yes. BID is twice a day. But how many people know that? Yeah. What is PO? What's PO mean on your medicine bottle?
By mouth.
By mouth. It means by mouth. But how many? Who knew that PO meant by mouth?
What does it
Yeah.
stand for? I know it's by mouth, but what is PO? Is it oral or what?
That's a good question.
It is.
I don't know. Yeah, it means, or does it mean oral?
It
PO,
does.
the literal acronym means oral.
Yes, it indicates that the medication is meant to be intake through the mouth.
Yes. Yeah.
Okay.
Yeah.
Okay.
Yeah, I know that that's what it ultimately means. I just don't know what the actual PO acronym, like what does the
Yeah.
P and the O stand for? I don't know. I
Thank
have
you,
to look it up.
Jessica.
You're
Yeah,
welcome.
yeah.
So
But
Alana,
there are others.
yeah, that's a great example of health literacy, and And that's one of those situations where, from my standpoint, I was working for the city government, and we started a program where we were bringing healthy foods into neighborhoods that didn't have access to affordable, healthy food. And we were giving medical and health presentations to help them understand how to read their lab results, to help them understand what these things were. But most importantly, we stressed to them that they have to get into a state of mind where they feel like where they should be asking questions every time that they go to their doctor, because again, like you said, sometimes these doctors uh, don't share the information that's important to know. I gave a presentation on diabetes prevention to a senior home, and when I was done, one of the gentlemen stood up and said that he had diabetes, and that he had learned more from me in that hour than he had learned from his doctor in the 15 years. He said for the first time he understood what the medicine was and why he should be taking it. He said his doctor never told him. He just gave it to him and told him to take it. So we try to press them to have some self accountability and to kind of own it a little bit, and always ask questions about anything they don't understand. And but in the beginning, you have to teach them how to ask questions just in general, like why this particular medication is better than another medication for me. Why is this the first option, or would it be better for me to exercise, or see a nutritionist or something like that to lose the weight, and those things. So it's a full on system that needs to be overhauled. But I think it starts with us
Yeah.
creating health fairs, seminars, education, so that people in our community understand how to address the medical professionals so that they can get the information they need.
Mm-hmm. And it's about being thoughtful, right? Like putting yourself sometimes in other people's shoes, or and not even thinking about how you want to be treated in this space, but how would somebody else want to be treated in this space. And sometimes it's that simple. Yeah, like let me ask them. Maybe the onus is not always on the patient. Maybe the onus is on the physician to say, pause. Like sometimes the pastor does at church. What does that mean? Talk to me slow. The pastor will say, "Talk to me slow." I think you know about that, Pastor Ralph Flowers. There, talk to me slow. What does that mean, Pastor? And take a step back sometimes as a physician and say, maybe they didn't understand that. Being thoughtful and maybe asking them to bring them along. But I agree. I love those examples that you brought forward, James, and sharing that. Unfortunately, someone had to learn from you, someone who just happened to walk into a space that they were in, to give them the knowledge that they needed to help care for themselves. But I think we have to be there for each other like that for that exact reason. Yep. So let's see. So yeah, so some of these are social factors that are impacting our healthcare, and I know I'm whittling down here. I think I have 3 minutes. So just to hit on barriers to change. So why do these disparities exist? So we have access issues, affordability issues, insurance gaps, and we know that we have the expansion of ACA. And then we also have cultural competency. Sometimes, especially when it comes to religious, cultural, different religions. I know in speaking with patients who are Muslim, sometimes, Muslim women wear the hijab, and sometimes there are assessments that need to be done with them in the room, and they're a male physician and a female who wears a hijab. There are sometimes things that they need to consider when it comes to that. They don't want to be in a room necessarily. It's against their religion to be in a room with a man by themselves like that. And so keeping those things under consideration when it comes to cultural competency. And then policy and bias, of course, the U.S. healthcare system is tied to our employment and it ties our employment and our insurance. And if you don't have a job, you often don't have insurance. And so that means systemic inequities, wage gaps, job discrimination, and health inequities overall. And then Just really quickly, some examples of some pathways forward. I actually even use the examples that you shared ahead of this, Lisa. So the Facts and Faith Fridays, VCU Massey, really cool. I looked into it, where the Black pastors and physicians partnered together to fight misinformation and build trust during COVID. Peer-to-peer referrals. Often 60% of people who are in these trials and going to the clinic find out about a physician or find out about a trial because of someone else. It is mouth to mouth, peer to peer referrals, and then policy solutions. Of course, I already mentioned Medicaid expansion and ACA protections that have reduced some coverage gaps, but it is not enough. So we need to advocate for more inclusive policies that really matter. And then finally, here is tangible solutions. And so what we can start doing for ourselves is knowing our health history, asking questions, just like you just said, James, using trusted sources like the National Institute of Minority Health Disparities in that department, Everyday Health and Healthline. There are opportunities to educate ourselves now more than ever. For our families, we need to normalize conversations about health and mental health and share where you can find affordable care. I think I have experienced myself in my family where it's like, oh, I never knew that was why this particular person died in my family. She had breast cancer. Like, nobody ever said that was why she died. Nobody knew that was why that particular person died and what the cause was until many years later. And those type of things really put you at a disadvantage because breast cancer can be genetic. And so not knowing the cause of death for someone in your family can negatively impact you. For our communities, supporting our local food banks, having health fairs, James, you ran down some of these already. Advocacy groups, sharing accurate resources. And then if you're a provider, if we have any providers on here, or you work with one or you live with one, sharing how to practice cultural humility, respecting the fact that you don't know everything about someone's culture, even if they look like you. Even if they walk in the door and that's another Black woman, you don't know everything about her. Respecting the fact that we need to ask, listen, and advocate for structural change inside the system as well. And so that was my last slide before this slide, which was just about discussion and Q&A. I think I ended right on time, maybe 1 minute late, Lisa.
That was awesome. That's great. Appreciate it very much. What barriers have you seen patients face? Wow. Wow. I was on a conversation today with 3 patients, and the fact that they were seeing a cardiologist who didn't even remember that they had had a procedure 4 weeks ago, never once asked how they were really feeling. They treated them by the numbers on the page instead of as a person. And didn't, somebody with peripheral arterial disease, PAD, didn't even take the shoe off. Those are barriers. And you said something very important. And to this group, I want to empower this group to have 3 standard questions, and I've got to figure this out, that whenever you or a loved one goes to a physician, you can always ask, because if you ask a question, it forces them to engage with you. And you said that about the question. So challenge me, group. Remind me, I want us to walk away with specific questions around a topic or something that everyone on this call or a part of the LMO conversations will have questions that empowers them when they go to their physician. So I'll stop there. That's awesome to think of what barriers.
Yeah. That's good. I actually had when my father was going through he had Hep C. He had gotten it from a blood transfusion many years prior. And so I would go to his visits, and his doctor pulled me to the side one time and he said, "Are you a doctor?" And I said, no. And he goes, you have so many, how did you learn all of this about this disease so fast? And you have all these questions. And I said, because that was important to me. I wanted to educate myself before I came to you. And I wanted to be prepared with questions that didn't make sense to me. And so we do have to own it for our parents, own it for our loved ones, own it for ourselves. And they like that. He told me, my dad ended up getting a liver transplant before he passed away, but he said, they're going to interview you. They're going to interview your dad. Can you make sure you're there when they interview him, because they're going to respect the fact that you're in there asking questions and it looks like you care. They take that as not caring sometimes when you don't ask questions.
Belinda, your hand is raised.
And the young lady makes a very good point about her being in there to ask questions. I went with a girlfriend of mine to the doctor last year before I came here, and she just wanted somebody to go for support. But the good thing about me being in there was when the doctors made a couple of statements, there were some questions that I asked. So if you have a really good friend, it's always good to have a second pair of ears to hear something, because you're so anxious that sometimes you miss some points. And if you have a really good friend there with you, they can ask pertinent questions to what's going on as well.
Yeah, that's good.
Yeah, I mean, I don't know. You have to give your permission for the person to be in the room, and sometimes doctors don't prefer that. But if they allow it, then it's a good idea if you can take someone with you, especially in an extremely serious matter.
Picture of black males with high blood pressure.
Mm-hmm.
Because I think I was 49 or 50 when I got diagnosed, but quite naturally, you don't understand. It's something, the first thing we thinking about losing our intimacy and stuff like that. So until I got sick one time from it and had to call in from work and got sick from it. But I went to a health seminar at the U.S. Postal Service. And, the doctor tell you to take the high blood pressure pill, but that's all he write prescription, but you don't understand the magnitude of what he's talking about. So when I went to the seminar, they say high blood pressure is like turn a water hose faucet on full blast. The water coming out the end of the hose and is falling on the petals of flowers, which means it's messing up all your internal organs. I got the picture. And that made me realize I lost from 243 to 213. I got my weight down, but still I had high blood pressure. So I take my pill. I'm not going, because my brother aorta bust on him at 50, he died.
Wow.
My daddy died of congestive heart failure.
Yeah.
So a lot of times people don't understand what high blood pressure is. They just think the doctors tell you to take a pill, and they don't want to take the pill because they think they can control their blood pressure. I'm just telling you, I talk with black males. Some kind of way they think they can control their blood pressure. And that's a myth.
Mm-hmm.
Okay? That's all I want to share.
Great example, Pastor Flowers. That's a great example. It's also a great example of health literacy, of the explaining something in a way that everybody can understand. Great illustration.
Yeah.
Mm-hmm.
And that's something important we have to do.
Community organizations. How can community organizations contribute to reducing disparities? Because it's important. I thought about it. I can't change my race. I can try to change where I live, but I can live someplace and the conditions of my neighborhood change over time. But community organizations like churches, like schools, like fire departments, I'm just the whole community. What can we do? And let's think about what we can do to do that. Our church just had a health fair brought in different organizations, did some screening, dental screening, mental health screening, calmness area, all kind AARP, all different places were there, bringing awareness to different groups, from different groups to the congregation. So that's one thing I think we're looking at.
Mm-hmm.
But I'd love to hear from other people about what your community organizations are doing so we can learn from each other. Oh, it's 7:24. I'm just talking. Y'all, I kept you, but this is a good conversation and Alana will be back. But if there's something you want to share, go ahead. And I do want us to put in the chat, what action will you take?
Yeah, that's good.
Yeah.
Do us a favor, you can get so we can hear the doctor side, because I've talked to several doctors, although we're saying what they do, but they talk about what we don't do.
Mm-hmm.
So we need to hear from the doctors what the patient don't do after they have given them all the information or tried to work with them.
We need to be better patients. Is that what you're saying?
Yeah, that's what you get what I'm saying. That's what one doctor told me, say they're coming there, they'll talk about the clothing that the nurse wears somewhere instead of being addressing their medical issues.
Mm-hmm.
Mm.
And so we need to hear the other side from the doctor perspective, so we can get both sides and get a holistic viewpoint.
That's good.
Mm-hmm. My chat's not blowing up. I don't see the action we'll take.
I have a quick comment. This is Stacy.
Hey, Stacy.
Hey, so the one thing I want to say is, don't be afraid to talk to your friends or your girlfriends or your male friends, or if you don't have family members, if you're going through something and you just need someone to listen. I had a procedure, a female procedure years ago that was very, very painful. All they told me to do is take a couple of ibuprofen before the procedure. And when I left there, I was in tears. I was like, I cannot believe that they thought 2 ibuprofens was going to prepare me for this. And then as recent as a couple of months ago, I had to have that same procedure done again. And this time I knew, I said up front, that's not going to work for me. We need to talk about some other things or some other options, because I know the pain that I endured, and I can take pain. I got a high tolerance, but I know I will not subject myself to this again. So what else can you offer me? And it was amazing. It was amazing what was offered to me, and so don't be afraid to ask people. In the Black community, it seems like we don't want to share and talk about things that we're going through, and we need to get past that.
You have to advocate for yourself and be unafraid to do so.
Yeah,
That's important.
that's a great example, Stacy.
Yeah.
Stacy, do you want to bring up the book?
So I'm not sure who recommended this book or if I saw it on TV or whatever, but I'm reading this book called No More Tears. And it's No More Tears, The Dark Secret of Johnson & Johnson. And, you have brought up the Tuskegee trials that they were doing. In this book, it talks about some of the things that, like the baby powder, the talc in the baby powder. I'm sure you guys know about that.
Yeah.
And some of those cases are still ongoing, believe it or not. And how more women were diagnosed with different forms of cancer, breast, cervical, because of being exposed to some of the elements that were in powders, because we use it for various reasons. Women do. Not only that, when we were putting it on our babies, we were exposed to it. And they also talked about there's a drug called, I think, is it Accutane, the one that's used for
Acne.
Right. They use that to experiment on Black men who were in prison, and they were burning their skin, and they were doing it intentionally because they wanted to see what the reaction would be on Black men that were in prison. So, I mean, I'm still like maybe halfway through, but every time I turn the page, it's like, okay, here's one more thing.
Yeah.
Like I said, though, they put those now. There's people in prison are considered a vulnerable population. And because of that, there are extra protections that have to go into place if you want to include prisoners on a clinical trial. Children are also vulnerable populations. People who work for pharmaceutical companies are vulnerable populations. Healthcare workers are vulnerable populations because sometimes you can twist their arm to do it because they work in the healthcare field. So like, I'm glad you bring that up because that's another example of protections that have now been put in place to protect populations like that.
Yeah. And it's good to know what that book offers, but it's even better to know those protections. So I think our challenge these days is to, when we hear something that was done, to try to understand, is there something that's been done to right it that was once wrong? So
Yeah.
this is great. I still see nothing in the chat. I got to put my own in the chat, but we will do that. What can I do to take action? I'm going to think of questions to empower this group that we can ask.
And
there's one in the chat. Who put that?
let me see. I was just going to suggest another book. It's called The Body Keeps the Score.
Oh.
And it is about how the mind, brain, and body are transformed by trauma. And just thinking about how the stress of situations can really impact our community negatively, and trying to figure out ways to better support mental health because of it. And so I want to suggest that as a read, but also the work is to figure out how to better manage our stress as a community, better manage our stress, better manage trauma, addressing things and not pushing them under the rug.
Very important. I mean, you talked about the alleles and the change when you look at cardiovascular disease and women in health, and you already brought it up in what you shared. The mere fact of the stresses that we go through have changed our alleles over time. So when you look at the longer that we live, it starts out that heart attacks start out being white man's disease. Then it becomes a black man's disease. Then it's the white woman's disease as we get older. And then guess who has the ultimate highest risk? It becomes black women. And look at all of the stressors. And it's the allele and the dimers that are on those genomes that are shrinking that show that. And there's that greater correlation in science that's there. So take care of yourself. Go when your husband's or I'm out on the golf course, I'm gonna go to the spa too. So I'm gonna do them both. Take care of yourself. Yeah, this was great, Alana. I look forward to your joining us with more solutions and more on health disparities. And please let us know how we can join the podcast. And we'd love to put that on our website and have that information for you. So you can send it to me and it can be posted so we can join you in your conversations. This is a group very motivated and interested in what they can do to empower themselves and then spread it to others. Thank you, team. This is wonderful. Thank you so much.
Good night.
Good night.
Good night.
Good night.
Good night. Thank you so much.